So when you decide to renovate a century-old house, you don't just, grab a sledgehammer and knock out a central load-bearing pillar.
Right. I mean, you'd assume the roof isn't just going to magically hold itself up.
Exactly. You put in temporary supports, you reroute the tension, you have to secure the structural integrity before the dust even settles.
Because if you just rip that center pillar out without a plan, the entire weight distribution of the house shifts. The floorboards sag, the door frames warp, and eventually your upper floors just collapse straight down into the living room.
Yeah, which is a complete architectural nightmare. But today, we are taking that exact nightmare scenario and applying it directly to the human body, specifically the female pelvic floor.
Yes, which is a surprisingly accurate comparison.
It really is based on the sources we have today.
Yeah.
We're doing a deep dive into a stack of clinical guidelines, NHS patient leaflets, and expert gynecological overviews. And our main mission is to answer a highly specific, vital question for you, the listener.
Right, a question a lot of people don't even know they should be asking.
Exactly. If you are going in for a hysterectomy and you're already dealing with a weakened pelvic floor, should vaginal laxity and prolapse be treated before, after, or during that surgery?
And to really get into the timing of these procedures, we first have to clarify the terminology. Because, well, it is heavily convoluted by private clinic marketing.
Oh, absolutely. The internet makes it so confusing.
It does. You see terms like vaginal laxity and pelvic organ prolapse used like interchangeable synonyms online, but anatomically and medically, they are entirely different events.
So let's draw that line clearly for everyone listening.
Sure. So laxity is currently categorized in the medical literature as a subjective sensation of looseness.
Okay, subjective.
Yeah, it's a loss of tone and friction in the vaginal tissue itself. Prolapse, however, is a physical, measurable herniation.
Meaning, like, surrounding internal organs are actually intruding into the vaginal space because the walls have given way.
Yes, exactly. If the bladder drops against the front vaginal wall, that is a cystocele. If the rectum pushes through the back wall, that's a rectocele. And if the uterus itself drops down the canal, that is a uterine prolapse.
Okay, so let's picture the pelvic floor as a heavy-duty canvas hammock holding up a basket of groceries. So your bladder, your uterus, and your rectum.
I like that analogy.
Right. So laxity is when the canvas itself loses its elasticity from weathering, it stretches and sags. But prolapse is when a heavy grocery item actually forces a deep physical bulge through a weak, frayed spot in the canvas.
That's a great way to visualize it. And that fraying happens primarily in the levator ani muscles.
The levator ani.
Yeah, these are the thick, interwoven bands of muscle forming that actual hammock sling. During a vaginal delivery, especially, a prolonged one, those muscles can stretch up to 3 times their normal resting length.
Wow, 3 times?
Yeah. And in many cases, the muscle fibers actually tear off the pubic bone entirely.
Wait, they literally rip off the bone?
They do. It's known clinically as a levator avulsion. It's a macroscopic structural failure.
Oh, man. So you have this physical tearing from childbirth. But our sources also highlight chronic coughing, like from asthma or heavy smoking, as major risk factors.
Mm-hmm.
How does a lung issue destroy a pelvic hammock?
It all comes down to intra-abdominal pressure. Every single time you cough heavily, your diaphragm violently pushes down on your abdominal cavity.
Oh, I see.
So if you have chronic obstructive pulmonary disease or COPD, and you are coughing violently 20 times a day for a decade, that equates to thousands of downward strikes against those levator ani muscles.
Just hammering away at it.
Exactly. Over time, the hammock simply yields to that repeated downward mechanical force.
Okay, that makes sense. But I have to ask about the estrogen factor.
Yeah.
Because the sources talk a lot about menopause. Menopause causes a drastic drop in estrogen, leading to genitourinary syndrome of menopause, or GSM.
Right, GSM.
If the hammock is made of muscle and connective tissue, why does a hormone drop cause it to fail? I mean, estrogen isn't a structural protein, right?
No, it's not a protein, but estrogen is absolutely critical for cellular turnover in the pelvic region. The vaginal walls and the surrounding connective tissue are heavily packed with estrogen receptors.
Okay.
When estrogen levels plummet during menopause, the tissue literally loses blood flow. The collagen fibers begin to fragment. The tissue loses its ability to retain moisture and elasticity.
So it dries out and weakens.
Yeah, the hammock doesn't just stretch. The material itself becomes brittle, frail, and significantly thinner.
Wow. Okay, so we have this frail, frayed hammock. And now we remove the most massive grocery item from the basket, the uterus.
Yes.
Which brings us to the core focus of the clinical guidelines we're looking at. If someone is scheduled to have their uterus removed, do they deal with this laxity and prolapse beforehand to strengthen the area? Or do they wait until after the body heals from the hysterectomy to fix the pelvic floor?
The clinical guidelines are totally unanimous on this. You treat it during the hysterectomy
Yeah.
at the exact same
Up to
time.
the as once.
Yes. Performing a hysterectomy on a patient with pre-existing pelvic floor defects, even just moderate laxity, is the single greatest risk factor for developing post-hysterectomy vaginal vault prolapse, or PHVP.
Vaginal vault prolapse.
Uh-huh.
Okay, walk us through the mechanics of that. If the uterus is gone, what is actually prolapsing?
So the vault is the very top of the vaginal canal, right where the cervix used to sit. The uterus acts as the central anchor, holding the top of the vagina up high inside the pelvis.
Like the center pillar of the house.
Exactly. When a surgeon removes the uterus, they sever the uterosacral and cardinal ligaments that were acting as the suspension cables. If those cables aren't reattached to something else, the top of the vagina has no upward support.
So it just falls down.
It simply collapses downward into the vaginal canal. It essentially turns inside out, like pushing the toe of a sock back through the ankle.
Oh, wow. If you're listening to this and you're scheduled for a hysterectomy next month, you might be panicking slightly right now.
Yeah.
How do you know if your surgeon is planning to prevent this? Do they just, stitch the front and back walls tight?
Well, stitching the front wall to hold the bladder back, that's an anterior repair, takes about 30 minutes and is routinely combined with the hysterectomy. And they can also do a posterior repair for the rectum on the back wall.
Okay, so they fix the walls.
Right, but fixing the walls doesn't stop the ceiling from caving in. The surgeon must perform a specific vault suspension.
Which is where the McCall-Coldoplasty comes in, right?
Yes, the McCall-Coldoplasty is a highly preventative surgical maneuver. While the patient is still on the operating table, the surgeon takes those uterosacral ligaments, the suspension cables that were just cut away from the uterus, and stitches them directly into the newly closed top of the vagina, known as the vaginal cuff.
So they are physically rerouting the tension.
Exactly.
They're building a new load-bearing pillar before they close up the walls.
Spot on. Another method is sacrospinous fixation. The surgeon anchors the top of the vagina deep into the pelvis by suturing it to the sacrospinous ligament, which is a massive fibrous band of tissue near the tailbone.
Oh, so it's really secure.
Very. It creates a rock-solid anchor point that just will not yield.
Wait, okay. If cutting the ligaments away from the uterus is what destabilizes the whole pelvic floor and causes the vault to collapse, the obvious workaround seems to be just don't take the whole uterus out.
You'd think so.
Right. Why not leave the cervix attached to those ligaments? Doesn't a subtotal hysterectomy solve the whole problem without needing extra suspension surgeries?
It seems like a perfectly logical and mechanical solution, but the empirical data proves otherwise. The Royal College of Obstetricians and Gynecologists explicitly state in their guidelines that a subtotal hysterectomy leaving the cervix behind is not recommended for preventing post-hysterectomy prolapse.
Why not?
Because the remnant cervix simply does not provide enough structural integrity on its own to stop the vaginal walls from eventually prolapsing if the pelvic floor is already damaged.
Ah, okay.
The most effective route is a total removal of the uterus and cervix, combined with immediate, robust ligament suturing while the patient is already under anesthesia.
Okay, so we know the protocol if a hysterectomy is already on the calendar. But what if there is no hysterectomy?
Right.
What if a patient is dealing with severe structural laxity decades after childbirth, and it's just ruining their quality of life? Let's get into the heavy-duty, standalone surgical repairs. I'm talking about vaginoplasty and perineoplasty.
Yeah, so vaginoplasty is the gold standard standalone surgery for severe structural laxity. It targets the mid to outer portion of the vaginal canal. The surgeon makes an incision, physically separates the vaginal skin from the underlying tissue, and locates those torn or stretched levator muscles we discussed earlier.
The ones that ripped off the bone.
Exactly. They reapproximate those muscles, meaning they pull the separated muscle bellies back together across the midline and suture them tightly. Then they excise or cut away the excess stretched out vaginal mucosa before stitching the canal back up.
It's the exact mechanism of a tailor fixing a suit jacket that is permanently stretched out.
That's a great comparison.
You can't just throw it in the wash and hope it shrinks. The tailor has to physically open the lining, cut away a strip of the excess fabric, and stitch the seams tighter so the garment fits the new dimensions.
And just like tailoring, the surgeon is permanently altering the structure. Simultaneously, they often perform a perineoplasty.
What does that do?
Well, the perineum is the area of tissue between the vagina and the anus, and it really takes the brunt of the tearing during childbirth. Rebuilding that perineal body is crucial for restoring the outward structural support of the entire pelvic floor.
The thing is, the brochures in private clinics always frame these procedures as a quick mommy makeover tune-up.
Oh, they definitely do.
But you're talking about stripping mucosa and suturing separated muscle bellies deep in the pelvis. What is the actual recovery reality for this?
It is a major invasive reconstruction. A patient is under general anesthesia for 1 to 2 hours. The recovery demands a strict 6 to 8 weeks of absolute pelvic rest.
Like 8 weeks.
Yes. No heavy lifting, no strenuous exercise, no penetrative sexual intercourse. And the complication profile is significant. Patients risk infection, wound breakdown, and severe scarring.
Scarring seems like a massive vulnerability in such a delicate, highly innervated area.
It is. It's the primary cause of dyspareunia or painful intercourse post-surgery. If the surgeon tightens the levator muscles too aggressively, or if the resulting scar tissue is rigid and lacks elasticity, penetration can become excruciatingly painful.
Wow.
It is a profound trade-off that requires careful, informed consent.
The sources also detail a completely different surgical approach for a very specific demographic. Colpoclysis.
Yes, colpoclysis.
This caught my attention because the mechanics sound incredibly extreme. What is actually happening there?
So colpoclysis is a procedure designed almost exclusively for elderly, medically frail women suffering from severe advanced pelvic organ prolapse. Rather than subjecting an 80-year-old with a heart condition to a grueling 2-hour reconstruction of the levator muscles, the surgeon performs a partial or total obliteration of the vaginal canal.
Obliteration, meaning they stitch the front and back walls of the vagina together permanently.
They physically close the space. It prevents any organs from prolapsing because the pathway is sealed shut. The surgery is very short, the risk of complications is remarkably low, and the anatomical success rate is near 100%.
But obviously there's a catch.
Yes, the definitive caveat is that penetrative vaginal intercourse is no longer possible. But for a frail patient whose primary goal is simply to walk without the severe pain of a prolapsed bladder dropping out of her body, it is an incredibly effective, life-altering option.
Okay, so reconstructive surgery requires general anesthesia, 8 weeks of downtime, and the risk of permanent painful scarring. It is no wonder patients are desperately looking for a shortcut.
Absolutely.
You walk into a med spa and you see an advertisement for a 20-minute pain-free lunchtime laser treatment promising to tighten everything up for $600 a session. Let's look at energy-based devices, or EBDs. Fractional CO2 lasers, radiofrequency devices like Thermova. What is the purported mechanism here?
These devices work by delivering controlled thermal energy directly into the vaginal tissue. A probe is inserted, and it heats the connective tissue beneath the mucosa to a very precise 40 to 42 degrees Celsius.
Why 42 degrees specifically?
That temperature threshold intentionally induces thermal damage.
It damages it on purpose.
Yes, it causes microinjuries in the collagen fibers. The body registers this damage and triggers a wound-healing cascade, sending fibroblasts to the area to synthesize new, tight collagen and elastin. The theory sold by these clinics is that this newly generated collagen plumps the tissue and reverses vaginal laxity.
But wait, if we go back to the mechanics we established earlier, structural prolapse and severe laxity are caused by torn levator muscles. The hammock fibers are literally ripped off the pubic bone.
Right.
Heating the surface mucosa to 42 degrees to build a little surface collagen, that's like coating the walls of a house with a cracked foundation.
That's a perfect analogy.
The surface might look a bit refreshed, but it does absolutely nothing to fix the structural integrity of the ripped muscle underneath.
And that is the exact mechanical disconnect the medical community is deeply concerned about. The marketing aggressively positions these lasers as a non-surgical cure for structural pelvic floor failure, which they physically cannot be.
It just can't.
Right. And the regulatory reality check in our sources is staggering. The U.S. FDA has issued explicit, severe safety warnings against using these devices for vaginal rejuvenation, citing documented cases of vaginal burns, severe scarring, and chronic pain.
Yeah, and our sources point out that the Australian Therapeutic Goods Regulator went even further. They have outright canceled all approvals for vaginal rejuvenation devices starting in 2025.
They did. They reviewed the clinical evidence and decided the risks simply outweigh the unproven, heavily marketed benefits.
And in the UK, the NICE-E guidelines, the National Institute for Health and Care Excellence, they concur, right?
Yes, they explicitly state there is insufficient, robust, long-term data to endorse the routine use of EBDs for vaginal laxity. They classify the treatment as investigational.
Are they entirely useless then? Because there are board-certified gynecologists who do use them.
They aren't useless for everything. Short-term, small-scale clinical trials show that thermal energy can be quite effective at treating the severe dryness and tissue atrophy associated with the genitourinary syndrome of menopause.
Oh, for GSM.
Right. By stimulating blood flow and collagen, they can help restore moisture to thin, estrogen-starved tissue. But treating menopausal dryness is vastly different from claiming a laser will shrink a structurally stretched vaginal canal after delivering a 9-pound baby.
Okay, so if lasers are investigational and potentially dangerous for mechanical tightening and reconstructive surgery is an absolute last resort, what does a listener actually do today? What is the undeniable, evidence-backed first line of defense?
The universal gold standard is pelvic floor muscle training, or PFMT.
Like Kegels.
Yes, we are talking about Kegel exercises, but elevated. It is highly recommended to do this under the guidance of a specialized pelvic floor physical therapist who can ensure you are actually isolating and contracting the levator ani muscles inside the pelvis.
Instead of what, just squeezing everything?
Exactly, rather than just clenching your glutes or holding your breath, which does nothing.
The problem with Kegels is that people try them for 5 days, feel exactly the same, and immediately conclude that pelvic floor therapy is a scam.
The failure isn't the exercise, though. It's a misunderstanding of the biological timeline. The clinical guidelines clearly state that a patient must engage in consistent daily PFMT for 6 to 16 weeks to see any measurable structural improvement.
16 weeks. Why does it take a quarter of a year to see a difference?
Because you are literally remodeling human fascia and muscle fiber. The pelvic floor is primarily composed of slow-twitch muscle fibers designed for endurance. I mean, they hold your organs up all day, every day against gravity.
Oh, that makes sense.
Building slow-twitch muscle hypertrophy and increasing the stiffness of the surrounding connective tissue takes months of repetitive, targeted tension. You are laying down new structural proteins. If you give up at week 3, you simply haven't given the biology time to adapt to the load.
It's like training for a marathon or lifting weights at the gym. You wouldn't expect a six-pack after one workout.
It's exactly.
You have to put in the consistent 16-week effort before deciding the gym didn't work and, moving on to surgery.
Very true.
What about the listener who is postmenopausal? If their laxity isn't from a torn muscle, but from that estrogen drop we talked about, the GSM, does doing 16 weeks of Kegels fix estrogen-starved tissue?
Well, Kegels will certainly improve local blood flow, but they cannot replace a missing hormone. For menopausal women experiencing that subjective looseness, the absolute first-line treatment is localized vaginal estrogen.
How is that taken?
This is delivered via creams, small tablets, or a silicone ring inserted directly into the vagina. It is completely different from systemic HRT pills because the hormone stays highly localized to the pelvic tissue.
So how does localized estrogen physically change the sensation of laxity?
It restores the cellular environment. The estrogen binds to the local receptors, thickening the vaginal epithelium, increasing elasticity, and restoring natural secretions.
So it basically plumps it all back up.
Yes. As that severe dryness and thinning resolves, the friction and volume of the tissue normalize. For many women, simply restoring the tissue's thickness entirely eliminates the subjective feeling of laxity, without a single surgical stitch or laser treatment required.
Wow. So if you are listening to this, you now have the blueprint. You understand the profound mechanical difference between a worn-out hammock canvas and a torn suspension cable.
And you know what to ask your doctors.
Right. If you are scheduled for a hysterectomy, you know to advocate for yourself and ask your surgeon, are you performing a vault suspension, like a McCall coloplasty, during my procedure? You don't wait for the roof to cave in to start building the support beams.
And if you are navigating childbirth recovery or menopause, you know to prioritize consistent physical therapy and localized estrogen over the immediate seductive promise of a med spa laser.
But the sources leave us with one final, broader reality to consider today. As childbirth and menopause naturally and inevitably alter the human body, we really have to look closely at the medicalization of female aging.
It's a huge point. We have to ask ourselves where the boundary lies between a genuine functional medical repair like fixing a severe prolapse so a woman can walk and live without pain, and a manufactured societal pressure to maintain a perpetually youthful anatomy.
Yeah, when an industry aggressively markets vaginal rejuvenation, are they treating a genuine medical symptom, or are they treating a socially constructed standard of what a woman's body is supposed to look and feel like indefinitely?
Are we treating the patient or are we treating the expectation?
Exactly. Something for you to mull over. Until next time, thanks for joining us on this deep dive.